as the, I'll start it. Got it. I'm proud to serve as the Eastern Cardiothoracic Surgical Society as the inaugural chair of the Committee on Justice, Equity, Diversity, and Inclusion in an ongoing celebration of last month's Pride. We bring you this initiative with the goal of improving the culturally competent care of our patients and the training of our residents and young surgeons. On behalf of the JEDI Committee and the Eastern, I'm honored to introduce tonight's speaker and guest, Dr. Allison McGregor. Dr. McGregor is a physician, author, researcher, and advocate. She recently moved from Brown to the University of South Carolina School of Medicine, Greenville, where she is Associate Dean of Clinical Faculty Affairs and Development and Professor of Emergency Medicine. She's the co-founder of the national organization Sex and Gender Women's Health Collaborative. Dr. McGregor's research focuses on the effects of sex and gender on emergent conditions. Among her many publications, medical and popular books and appearances, I can personally attest to her giving an outstanding TED Talk that has over 1.5 million views. And this has sparked a national conversation around how sex and gender influence medical treatment and outcomes. On behalf of our committee, the society, and its members, welcome Dr. McGregor.
Thank you, Dr. Wolf. Yeah, thank you so much. I am so excited to be just part of this group for a little bit because I'm just so excited that we have such amazing women leaders, as part of this. So let me share my screen. So I've already been introduced, which is wonderful. And I just want to give kind of the lens of where my experiences are coming from and the lens of the literature that I'm looking at, which is I'm an emergency medicine physician and I've been such for 18 years. And it's really been amazing because I have seen the entire breadth of like the human condition, like what's possible, happens and it comes in. And this is the lens of my patient experiences and really understanding where the floor of medicine really falls through, where biases are really front and center. And so I have two books. One is a medical textbook, and then the other is a lay book called Sex Matters. And so I will just do this. So I think just like we're just going to take a few minutes with these slides to just kind of create the arc of understanding, because once you realize how we got into this situation and then where the future is going, I think that your specialty can really take it from there to move forward. And then at the end, I'll have just a quick, some suggestions that can be used. So how did bias become integrated into our medical framework? It really goes back to when we were taught biology. And it's still being taught this way, which is really nuts. We're taught that the egg and sperm come together and then that decides whether you have XX or XY, that decides whether you have ovaries or testicles, and then that regulates testosterone or estrogen. And then the testosterone and estrogen regulates secondary sex characteristics. And then we start to put it aside. We were just like, okay, that's the cycle. Yes, that's right. Okay, and next. And then what I saw in medicine is that there are major differences between men and women outside of the reproductive health systems. If we just look at autoimmune conditions, almost 80% are all in women. I was taught in medical school, female fat 40 fertile for cholecystitis. And it was never told why that was the case, right? So we're looking at those things. Why are migraines so common in women? And irritable bowel syndrome, so many syndromes that every time we don't know what it is, especially in women, we just give it a syndrome, a constellation of symptoms. But men are 30 times more likely to die of sudden cardiac death during exercise. And we don't really know why that's the case. Cardiomyopathy, heart failure with reduced ejection fraction, preserved ejection fraction. Those are all really now coming out with this really interesting science of the difference in the physiological response to high blood pressure between men and women. So to me, this is really exciting. But what happened? Why are we just discovering this now? Our research was done on enslaved individuals. There was a lot of need for human rights protection. There was no IRB. There was no informed consent. So in 1974, the National Research Act came and said, wait a minute, we should have all of these really important things. However, we've had the examples of the teratogenic effects from thalidomide. And so let's, while we're creating these protections, let's protect women. And so women were just removed from the pipeline. Until about the feminist movement, NIH Revitalization Act 1993, where there was this thought that, we have to include women and minorities into the study, especially later stages of studies. So it was like, okay, yes, we should probably reverse that part of the 1974 Act. This is 20 years of a very pivotal moment of our research. We have the Physicians' Health Study, which created lots of understandings of cardiovascular disease in white doctors and men, because they were the only ones allowed to really, do that at that time. So most of our understanding of cardiovascular disease, cancer, stroke was really during this time where women were not included. And so what happened with that is that something like Ambien. So for those of you who aren't familiar, this is a really flagship example of what happened. Ambien was on the market for over 20 years. It was studied in men and mostly prescribed to women because women are more likely to have sleep disorders than men. So what happened was 20 years of prescribing 10 milligrams to mostly women. The only time we were able to really capture when things went wrong with women was post-market surveillance, right? Because they weren't part of the studies. So then it gets approved by the FDA, it's out there being prescribed, and then thousands of reports came in about women taking Ambien the night before and then getting in their car in the morning and having impaired driving, motor vehicle crashes. I handle motor vehicle crashes all the time. It's a crisis. That is serious consequence. And so the FDA looked at it and they studied, and they asked the pharmaceutical company to study. And what they found is when they gave 10 milligrams to both men and women, and they checked the serum concentration after a certain amount of time, women had 2 times the serum concentration compared to men. So they metabolize the drug at a slower rate. So they're waking up in the morning with still a lot of active drug in the system. And so this was the first sex-specific dosing recommendation that was made by FDA. So right now, men should be prescribed 10 milligrams and women 5. And so here's this like crack in the system of like, well, this is one drug. There are a million drugs that we rely upon that should be studied in both men and women and maybe have different, reasons for dosing, efficacy, side effects. So now the NIH said, well, gosh, that's really interesting. And maybe it's too late to throw women in at the later stages of the study. We have, lots of buildup of what we're creating our next study upon. And so cell lines and animal studies and the earlier phases, the NIH said, as of 2016, if you apply for funding from us, we must include sex as a biological variable in the study. And so that was a wonderful step. You don't need NIH funding to do a study. Pharmaceutical companies don't necessarily need NIH funding to do a study. So, but at least it sets a precedent of, okay, this is important throughout the entire research pipeline. Now, this is what we're learning even further than that. So this is an example of a study that looks at high dose naltrexone, so naloxone orally, for the use of cocaine use disorder. And so the bottom is looking at time, and then the vertical axis is looking at the amount of cocaine use. And so this study is a double-blind placebo study, and it looks at, okay, let's look at men and women and the amount of cocaine use that they do over time And then we gave them a placebo. I didn't, they did. And they looked and said, okay, they do about the same amount of cocaine use over time. But then they gave the men the study drug, and they noticed that the study drug was actually helpful, and they did less cocaine use over time. But when they gave the study drug to women, it was actually harmful, and they did more cocaine use over time. So this really is just one example to highlight the difference in sex stratification of analysis, right? We're not just talking about including women or including female animals or including XX with XY cell lines. We're talking about analyzing the data separately to see if there is a difference. Because if this researcher pulled the results, like most of us do, then it would have shown no result, right? It would have just shown like, oh, we missed something, you know, and really highlighting. This is another article that was published in Nature that shows the same thing, and I think it's really well done. So if we were to just assume that there's no difference between men and women, and say we use the same example, and the measured variable is cocaine use, and then the treatment A is placebo and B is the study drug. When we don't analyze the data separately, we're making this assumption that there's no difference between men and women. So you're making this assumption that if we were to unblind the pooled data, that it would be just scattered, you know, appropriately, and there would be no major differences. But when you stratify by sex, there are so many other conclusions that you can make. For instance, for this one, women are in red, women are in blue, and men are in red. So say the placebo, women just did more cocaine use than men. And then when they gave the study drug, it was the opposite effect that we saw. Or maybe there's no difference between the study drug or the placebo, and men did more cocaine use. Or maybe there's a scattering of cocaine use between men and women when you have the placebo, and that's just a point in time in the environment. And then when you gave the placebo, when you gave the study drug, women did less and men did more, which is the opposite of what we saw. So this sort of unblinding of things, I think, is really critical for how we look at research when we are doing it, or when we're critically evaluating the research. Did they stratify by this? Can I take the result and apply that to my patients? And so this is really now the next step, is when we're stratifying by sex, we're learning that, oh my gosh, okay, there's a difference between naltrexone and between men and women. There's a difference between Ambien between men and women. Why? What is the source of that sex difference? And this is really leading to good research, reproducible research, which the medical and social sciences are the worst in reproducibility. And I think it's because we really just sort of missed this. So a couple of the main things that we're looking at is that result due to biological sex? Does it have to do with the sex chromosomes? Because those sex chromosomes are not just in the ovaries and the testes, they're in the liver, and they are affecting the pharmacokinetics of metabolism of drugs. They're in the kidneys. Tylenol, propranolol, benzodiazepines all have quicker excretion rates through the kidneys in men than they do in women. Do we have different prescribing mechanisms? Propranolol lasts about 8 hours longer in women. There's no dosing recommendations based on these things. The gastric emptying time is slower in women. The intestinal transit time is longer. There are more COVID receptors in men in the lungs than in women. And so that's what's leading to, one of the major reasons leading to higher mortality rates in men. Cardiovascular disease, gosh, I mean, those coronary arteries have these sex chromosomes in them, and they're leading to more microvascular disease in women. They're leading to different relations to heart failure, on and on and on. So this is really, really exciting. Is the sex difference due to hormone levels? Men and women have varying hormone levels through the lifetime. Women have varying levels throughout the month. Men have diurnal variations as well. These men in the ages of 20, 30, and 40, this has been our subject sample for the things that we all learned in medical school and residency. That has been our understanding of health and disease. That is not applicable to real time for anyone else. For instance, I see women with seizure disorders, and there are many seizure medications that dip below therapeutic levels during certain phases of the menstrual cycle. What do? I tell them they can't drive. I increase their dose of Dilantin so to cover for all of it, right? When they don't need that high dose except for a certain time. So we haven't tailored any of this to our understanding of treatment. Is it due to environment? So is it due to gender identity, or race, or weight, or ageism, or ethnicity, or sexual orientation? Not all of these environmental attributes are visible. But one example I like to use, just to set it home, is women who live in a culture where their gender wears a burqa. So if they're covering up, think about what is their likelihood of their risk of skin cancer. It's probably lower, right? What is their likelihood of vitamin D deficiency? Probably higher, right? And if you want to hang out in my trauma rooms, you can see the men are falling off of ladders, getting their fingers cut from snowmobiles, because men are expected to do the hazardous things in our environment. So these types of impressions affect our access to health, affect our, our overall health. What's really cool now is looking at the intersectionality of all of this. I love this study. There's a lot coming out from some of the pharmacological literature, which is starting to show that, okay, what about transgendered person? So one of the things I teach is that when I see a patient, I think, what is their biological sex? And then I want to look at the literature for that. And then I want to look, okay, what is their gender identity? And then I want to look at the literature of that. And then I can individualize it. But now the hormone status is so important that a lot of transgender individuals are taking exogenous hormones, right? So what's happening with that? What category am I looking at for the literature? And what they noticed is that when an individual is taking testosterone and estrogen for over 6 weeks, their creatinine clearance and their sort of total body, their lean body mass changes to that of the gender that they're conforming into. And so their push is that we should be collecting this stuff in our electronic medical records so that the pharmacist can recommend and say, this particular patient is transgender, they're on these hormone changes. So let's use this as the dose, or let's use this as the increment of when just like we're doing now with body mass and weight. I mean, we never even thought of weight for so long. And now we're actually including that into some of our dosing recommendations. And so this to me is really exciting. I think it's going to lead to a lot better treatment. What has happened from not including any of this into the way that we practice right now? And really, it just takes one example. We have been using the evidence as it was, especially during all those years of using men with stable testosterone levels. And we're using that as our evidence-based. We say we use evidence-based medicine, and we give lectures on it. We really sort of, we come around that as like this is, as doctors, this is really important to us. Well, you have to think about what the evidence was based upon. And if the evidence is based upon, people who are doing sex-based research, cell-based research, they don't know the sex of the cell. They don't know if it's an XX or an XY. They don't know how that affects the outcome of their analysis. 80% of animal-based research is still male animals because it's thought to be easier. They don't have to think about a menstrual cycle. Well, it's time to get complicated. right? I think when research was first coming, we really wanted to make sure everything was simplified, no confounding factors. That doesn't apply to real life and our patients. I was asked to do a talk for this international review course for medical students or residents that they are teaching them for the boards. And these were their slides for for heart attacks. This is their MI slides. This is not the only person who has an MI, right? It's not always the man with metabolic syndrome, sweating with chest pain going down his left arm. This is a false narrative. Women have heart attacks as well. And it looks different, and it can look like this. It can look like a cold sweat, shortness of breath, nausea, fatigue. You guys all know this, but not everybody does. So the patient doesn't know that. And then when they call 911, the ambulance doesn't necessarily want to bring them in because they're like, this isn't a heart attack. And then the triage nurse is like, well, why don't you, oh, this is just nausea, go sit. Delay. And then the doctor may not know that. And then the cardiologist may not know that. And then this goes on and on and on. This is why women have greater mortality rates after having a heart attack. They're less likely to be on evidence-based therapy because no one's even thinking that these symptoms are the cause for the heart attack. A quick example of using sex-specific information and evidence to make that change is with sex-specific troponin cutoffs. If this was an in-person thing, I would love to find out who actually uses this. My hospital now does not. My hospital before just started to. And this is just an example of, if we're using a reference range to then put you on a path towards treatment, then we have to make sure that those reference ranges are sex specific because women have smaller hearts. They have smaller coronary arteries. They're going to have different levels and ways of releasing troponin into the blood. So if we don't take these things into account, we're missing these opportunities. We have individual biases. I was just part of a group that gave a talk at the Society for Academic Emergency Medicine about LGBT. And we all said, my name is Dr. McGregor and I am biased. We were taught pattern recognition. We're taught by our teachers. We're taught by our family members. We are grown up with this, real sort of ingrained system of how to think. And so we have to realize that this is something that we have to understand. I am so excited about this new literature coming up. And I just want to show some examples, which is the sex or gender of the physician actually can impact health and outcomes. So here's one, and this is just, all this stuff is just new, and it's really, really interesting for me. So the association of discordance or concordance of the sex of the doctor to the sex of the patient. And this has to do with surgical outcomes. And what they found out is that when there's a sex discordance, that there's worse outcomes for women. So if you have a woman surgeon and a woman patient, the outcomes were better. And if you had a woman surgeon and a male patient, the outcomes were better. That when there was, so what outcomes, big outcomes, as you can see. What are some of the thoughts of this? Are women better surgeons? I don't think that that's the result of this. I think that this is just uncovering some really interesting hypotheses. One thought for this is that maybe communication style really is important. So if you have a woman surgeon and they're talking to their woman patient, maybe that woman patient is more likely to say, you're right. I'm gonna take your advice. I'm gonna do what you say. I'm gonna do these things that you've told me to do, or take this medication. Maybe there's more of just a linkage in that. It's not just surgeons. This is a huge study out of Florida for Medicare patients that looked at admitted patients through hospitalists, and when they had a male physician, that they had higher 30-day mortality rates, higher 30-day readmission rates, right? So what does this mean? Well, some of their thoughts are women are more likely to follow hospital-based guidelines. Maybe that's just it. Maybe it's the communication piece. And emergency departments are no exception here. So this showed that when a female patient had a female physician, they had better survival. Okay, these are big outcomes. And not only that, I think this is kind of a key take home, is that the men who had women colleagues also had better outcomes than the men who didn't, had less women colleagues. So I think this is really just a thought about diversity, uncovering some biases. If we diversify our workforce, then we are better able to handle our diversified patient population. And I think that's really critical. Our current pipeline. So I did in part of doing a study at Brown, and it's about integrating these concepts into the way that we're teaching medical students to make sure that we are incorporating these variables when we're teaching. That's the main component. The only thing I thought would be really interesting to show you is the demographics, so that we have an understanding of who are our residents, who are our future residents and our medical students, who are our younger faculty, because this is really changing. And so we're going to have to be very keen to adapt to this concepts by vocabulary, by our slide intentions. So I just looked at the sex assigned at birth, and you can see that it's about faculty. It was people identify as a male or female, and some preferred not to disclose if they were students. But when I asked what their gender identity is, if you look at the top with faculty, it was really cisgender man and woman. So that means their sex and their gender match. So they're male sex and man gender versus female sex and woman gender. But when you look at the students, and what I wanted to do is make sure I gave them lots of options. I did this with my fellow who is from Iran. And one of the things we wanted to make sure is that they could find the box that they could check, right? So and that happened with the ethnicity, and that's why. So I wanted to make sure, if there's a box that you identify with, you can check it. Look at the difference between gender identity in our students. People identify in so many different ways. Sexual orientation. Look at the difference between faculty and students and the way that they identify. And so I think this is really critical to know that this is kind of where society is headed towards. And then this is where our medical specialty is headed towards. What current education looks like. Okay, this is the ending. This is like two nuggets that you can do when to start to try to figure out, how am I supposed to look at all this? Because the evidence on sex and gender, it depends on, a cardiothoracic surgeon over here is doing this amazing stuff and just published this one thing. This dermatologist over here just found this difference between, between men and women. There's no this one specialty to be able to look it in. So this group developed a PubMed search tool that will review all of the literature and then bring in the sex or gender differences. You can access this through sexandgenderhealth.org, which is through the Laura Bush Institute for Women's Health and Texas Tech University Health Science Center. This website has so many amazing things, and I've been happy to help, have a little piece in putting together some of their stuff. But if you look at resources, and then you go to the literature search and database resources, it automatically populates a PubMed search tool, like on the bottom. And then you can add whatever you want. And so I thought for this example, I used appendicitis because I thought, let's think of something surgical. And so you add that in, appendicitis plus this search tool, and it combs all the literature. And you know how many thousands of papers there are on appendicitis? 39 results. So anytime where sex or gender was a factor in their title, in their outcomes, in their analysis, you can pluck that out. And now it's like, oh, wow. So I've established an entire elective based on this, where I have a student come in or a resident come in and see a patient and then say, use this PubMed search tool and teach me something specific about the fact that they have a, look at their asthma medications, look at their, their stroke history. You can use anything and then start to be able to incorporate this new stuff. Most of the stuff that you will find in here are very new. The literature is very new and it's very exciting. And so this is a very a good way. This textbook is also awesome. And it's just about a year old. It is the most comprehensive way to go through how to actually integrate all of this stuff, how to make this part of your clinical practice. And they have checklists for all topics. And I looked, and the cardiovascular topic, of course, is really brisk. And it will have checklists of if you're doing bedside teaching, how to make sure that your bedside teaching is up to date on these things. What are some of the checklists that you can think of? How to make sure that when you do a slide, what's missing? How to make sure that you're practicing inclusive, inclusive, updated, relevant, and generalizable to your patient medical care. So I thought that would be a good overview. I think I stopped sharing, right? Okay. Yeah, just an overview of like where the arc is in 20 minutes. And I'd love to just hear either questions or just, is this new for you? It's just is this overwhelming? Is this exciting? I would be happy to have a discussion.
Thank you so much, Dr. McGregor. I just want to take a minute to say, wow. I mean, you covered a lot of territory there. And even having seen some of your work and seen those slides in advance, I was still blown away. And there's so much that we can discuss. So I just want to say thank you. And thank you how nicely you put that into even just a short talk. So, wow, great. I do want to give people a chance to ask questions. I do have some that we can start with, but I want to welcome people to ask questions either audibly by unmuting yourself or to put it in the chat, whatever you're most comfortable with. Maybe I'll start if you can. I'm most interested in this, the impact or how some of these things relate to hormone differences. Whenever we talk about sex differences in disease processes, we immediately start trying to think about how it might be related to hormones and how therapy related to transition might impact that. And so I was wondering if there are any areas in which there is research that is showing us what's happening here and how that impacts patients who have undergone or undergone transition.
I would love to say that there's so much out there. It is so understudied. I mean, we're just trying to study women, never mind, transgender individuals. So there's a lot of work there to be done. Where I've seen the most impact, though, is with pharmacology literature in that respect. Because when you think about it, if you just look at the female menstrual cycle and you think of the changes that occur in the body, all over. I mean, we're used to just thinking about it in the uterus's point of view, but if you think about it all over, that's changing your entire metabolism. Now think about the spikes of those things during pregnancy. I didn't even get into the fact that we don't study pregnant women. We study pregnancy, but we don't. Pregnant women get sick and sick women get pregnant, and we just, we're still calling them protected subjects. So there's so much more work to be done. I think one of the basic things that we can do is when we are doing clinical research ourselves, or we are peer reviewing something, or we're an editor, or we are on the IRB committee, is to make sure that that demographic sheet, the table 1 usually has biological sex, current gender identity, and then any exogenous hormone levels that are, we need to start to look at that so that we can make that part of the sex stratified analysis. That's the only way we're going to really understand this. And so I think, that is really where the future is if we want to look at mechanisms of differences.
You know, we have a few oncologists in addition to the surgeons on the call, just because I recognize some of the people. This is something that's been of interest to us in as some of us thoracic surgeons and oncologists treating lung cancer, mesothelioma. This is something that I've really been fixated on, I think since I was a resident, and first trying to understand why there are differences in outcomes for mesothelioma, big sex differences in outcomes. And like you described, we don't even understand how it is affecting women. So it's hard to extend to how it is affected by exogenous hormones. But that's something that we really do need to incorporate. I think that's one of the lessons here, is that part of clinical studies and research and clinical research is including that information. I think that's always been sort of my bugaboo, is trying to figure out, were people taking external hormone replacement and how that would affect their cancer. There's a question that was sent to me directly. Have there been differences in treatment for patients undergoing hormone suppression? For example, people on Lupron for prostate cancer, or breast cancer, gynecologic cancers. Oh, I think we just lost Dr. McGregor. I think she was frozen. Maybe she's re-logging in.
While we're waiting for Dr. McGregor to log in, I think one thing that I found interesting in terms of my review of dealing with the transgender population has been things that we don't quite appreciate, you know, the airway issues for someone who's transitioned from male to female, in terms of they will have a difficult airway. The double lumen tube will have to be longer. And so, and I think in terms of cannulas and those kinds of things, I mean, it's physics, but it's something that we really need to engage our anesthesiologists as well as a perfusionist in order to be able to accommodate those patients.
I'm sorry, that was me, right? I
Yeah,
apologize.
no,
All of a sudden I was like, oh, you froze. And I'm like, everybody froze but me. That means it's me. Sorry.
Thank you for coming back in. I said, I think we just lost Dr. McGregor. But, oh no, I think she froze again. Uh-oh, maybe it's her internet connection. No, thank you, Sharon, for bringing that up. Yeah, I mean, it's relevant for multiple aspects. I kind of talked to my partners about this today. I said, picture your transgender female esophagectomy patient who no one knew how to place a Foley in because she'd had surgery. And you, I think, raised the question that regarding the neopenis and catheterizing that.
And I think for those patients who are NPO, you know, whether it's after a esophagectomy or, you know, any sort of gastric procedure, it's trying to talk to their physician who's in charge of their hormones. Are there alternatives besides something orally? Can we give them something transdermal in order to help accommodate them?
I think she's trying to log back in. I don't know, thank you guys for logging in. I'm sorry, we're having some technical issues. I want to bring up the women's lung cancer thing. I think something Cy had raised, and it's always something that I think several of us, Dr. Dorshow and Dr. Fitzgerald, are medical oncologists at Sinai. But this whole trying to get the traction of the movement to engage primary care doctors, pulmonologists, everyone in thinking, and GYNs, and thinking about lung cancer as a women's health issue, given how much of an impact it has on women's health. It just hasn't gained any traction. So I wanted to ask for her advice about that.
Not only that, but I see some major discrepancies in terms of treatment of women, because lung is not considered a women's cancer. Hi, I'm Debbie. I work with Andrea. I'm a medical oncologist. But for example, you know, our medications make patients lose their hair. And we have several sets of equipment for scalp cooling that are available for female patients in the breast center. There is no equipment available for women in getting treated for any other kind of cancer in the hospital, and more women get lung cancer and other cancers than even breast cancer. And that's just, I think, one example of a major major gap.
I know, you know why? And I'm not saying I know why, but I'm just going to comment, is that when we made women protected subjects and then we studied men, the only thing we couldn't study in men was the reproductive system in women. So pregnancy, menopause, menses. So then we studied those things in women, and then that became the entire capsule of women's health, their reproductive issues. So women, still to this day, if I ask what their, greatest health concern is, it's usually breast cancer. And I always tell them lung cancer is the #1 cancer killer for women. And so, so I think there's been this whole sort of wave of healthcare for women that's only equals their reproductive health system. I just had a friend who is very much an executive, a high-level executive that just had breast cancer, and she used the cool sculpting, and she was able to continue working. And I didn't realize it was just offered through breast cancer. So that's fascinating.
Most of the time, yes. I mean, part of it is also because the funding for breast cancer compared to other cancers is very unevenly distributed, in part because the advocacy community for breast cancer, which is wonderful, was the first advocacy community to develop in oncology in the 70s. And so they have a tremendous infrastructure, and that has led to a lot of wonderful things for women who have breast cancer. Unfortunately, that has not, helped women with all other kinds of cancer.
I agree 100%. I think we have to make sure that women are seen as valued out, in every other part of their bodies, and really sort of incorporate that into the advocacy, into policies, into money. I'm on the NIH Office of Research and Women's Health Advisory Committee, and we just had this talk about Congress mandates what the NIH should focus on. And so one of the things that they just asked us to focus on was chronic conditions, which I thought was amazing because that's huge. Cervical cancer and maternal mortality. And so I think it's got to be all it's got to come from top down and bottom up and in the middle. And I think, wherever we have a sphere of influence, to make sure that we bring up these issues that you're presenting right now.
Thanks so much, and really interesting discussion. It had started as you had the technical trouble that Dr. Giorgio and the rest of us and Sai had brought up this question as well, why we can't seem to gain the traction for lung cancer as a women's health issue, and what advice you might give to help us do that. But I think you've answered that quite well. We just have to keep banging the drum. I am very interested in the literature on physician-patient discordance, not just for its implications with gender, but also with race. And it's one of my arguments for increasing diversity in our specialty in order to improve the care of our patients and reduce the healthcare disparities that we see for lung cancer, esophageal cancer, and others. It gives me a little pause, though, when I start to say it out loud and think of what the implications might be if applied too broadly. And does it say anything about whether a woman should be treating male populations, or whether a white physician should be treating predominantly Black communities? And these are difficult subjects to discuss, but also difficult to understand. How do we approach that?
Yeah, I do have other studies that sometimes, if I have more time, that it's shown that when you have a diverse physician group dealing with a diverse patient group, that they do better. So the same things that I just showed regarding sex and gender have also been shown with race. And so the bottom line, I think that the bottom, the common denominator through all of these is that diversity matters of the physician group. And so even when you have, say, white men taking care of men of color, and then you just take that physician group and you add some diverse men of color, then those white men are going to take care of their patients of color even better, because we're at the water cooler, we're having understandings, we're at the faculty meetings, we're talking about cases. So it's not that white men are ignorant. It's that we're all siloed into our own biases. And so when we share our experiences and we start to look more like our patient population, then we're all, a rising tide lifts all boats. And so I think that's really important for things like leadership positions. So a lot of the literature also shows that when you have a woman who is either the first or the last author on a paper, that they are more likely to enroll women and have sex-based analysis. So women think of women, men of color think of men of color. And the more that we have this diversity, I think throughout is important. I think we also need to have that diversity in how we enroll subjects into clinical trials. We can't have, people aren't going to trust, if we think about Tuskegee and we think about World War II and all of these horrible experiences that we've had by studying enslaved individuals, there's a lack of trust if you don't look like everybody else. So making sure that you have those that are very diverse, that's going out to enroll subjects is really important. If you go to community centers and churches and local gatherings, you have to really be active and sort of and look the part. And so I think it's a double-edged sword. The more we become diverse, the more we have leaders that are diverse, the more that we will all understand how to handle and improve the health of everybody. So it's really entrenched into a lot of the society roles, but it's it's good to just talk about it. It's good to think about this. No, we're not perfect. We evolve. That's one of the things I try to end a lot of things with, is that it's okay. We never wore gloves. We probably will never not wear masks. Well, in my situation, we evolve in our concepts and, as scientists and as doctors. And I think that's really important to just keep in mind, that it's to uncover these biases so that we can continue to evolve just for the sake of science and medical care.
Amazing. Thank you for articulating some of these really important issues. That's so well said. On that subject, and certainly I want to make sure we address this before we start to close, is resident education and training of the next generation of physicians. And if you can help us think through some of the most common ways in which faculty might unintentionally show gender or sexuality bias when interacting with trainees.
Yeah, I think my new role now as Associate Dean of Faculty here is really, that's kind of my next, that's what I'm concentrating on right now, which is, in order for the faculty to be successful at teaching this new generation, we ourselves need our own faculty development. So we need to specifically bring in, say, thank you for having me talk to this group, and hopefully more will happen, but to really make sure that there's some sort of intentional faculty development to make faculty feel like they are not afraid. The study that I was doing, that I mentioned earlier, the comments from faculty were, they were afraid to say the wrong thing because students, they're going to call them out on it now. If you say, you have to say things like, it's not just men and women, it's maybe non-binary. It's about persons that can have birthing persons. We're all sort of like, okay, this is, I'm not used to using this language. I'm not aware of my biases as much as I should. And so we are actively creating programs of where we can show the faculty, oh, look, let's look at your slide show for this particular teaching point. And then you can say, maybe if you have different, pictures, and make sure that there's more variety. And then just to feel empowered to mess up, just to make sure that faculty don't feel as though they have to be perfect, because this is, it's evolving so quickly. So I would really encourage whoever's responsible for faculty development at each group to specifically look at creating videos and programs and lectures and workshops to make sure that faculty feel as though when they are teaching residents that they are at least equipped to feel as though they are confident to continue giving that mastery that we've all worked so hard to develop. It's just a different language now, and to teach the residents how to look up this new information, like that PubMed search tool. Let's learn together. Let's look at let's use this and look this up, and then come back to me. A lot of times I'll say, that's a great thing, can you look that up using this, and then teach me, because I don't know everything. Nobody knows everything. And so empowering the residents to feel as though they can also teach you about this, I think would be really helpful as well.
That is super helpful guidance. It's funny to come full circle and then to be faculty and realize that you're sort of at this point where you're again afraid to ask questions. It's kind of weird, but it's true.
Yeah.
Are there other questions for Dr. McGregor before we close, opening it up to the audience? There have been some nice comments and some really interesting things in the chat. It is making me want to go down to Greenville.
Come on down. We're recruiting. We're a fast growing system here. So that's great.
I want to thank you again. Really, thanks. The preparation for this and tonight's talk were really outstanding. You've really taught me a lot, and I look forward and hope to collaborate again.
Absolutely. And thank you for wanting this. Honestly, you just put yourself up, ahead of the game. And so I'm happy to be available for whatever comes up.
Thank you. Thank you. I want to take an extra second to again thank Dr. Sharon Ben-Or, who had the idea for this, but is also the first female president of the Eastern Cardiothoracic Surgical Society, which is amazing. And I think, and there are others in the pipeline. I look forward to hopefully Dr. Wallace being soon in the same position. So really cool. Thank you, everyone.
Have a great night.
Have a good night, all.
Thank you, Dr. McGregor. That was amazing.
Thank you. Thank you. Thank you for inviting me. Good luck in your presidency.